Well, hello everybody. Welcome back to the Incubator Podcast live at Hot Topics in Neonatology 2024. And we are joined this Wednesday morning by our first guest, Dr. Jochen Profit. Jochen, welcome back.
Good morning, everyone. So excited to be here.
Yeah, we were reminiscing that the last time we spoke was at CHNC. And so it's great to have you back.
Yeah, I think we were also at the Neck Society.
And the Neck Symposium as well. That's right.
Yeah. So it's good to see you guys
Did I
again.
mix that up?
I think so.
All right, that's fine. First mistake of the day. We're going to put like little strikes.
Yeah.
I said we were in Ann Arbor yesterday.
He messed up the location yesterday.
You can understand what
He
my
didn't
life.
even know where we were. But anyways, we're on the third day. It's very exciting.
Yeah.
Yes.
And Jochen, you for the people who are not familiar with who you are, you're a neonatologist at Lucile Packard Children's Hospital, and you're a professor of pediatric at Stanford University School of Medicine in California. You have a lot of badges on your ID. You're a faculty.
I know.
It says 20 plus years.
It means I'm old.
That's your age, right?
That's my age, exactly. Yes.
Program chair.
But that means you've been coming to this conference for 20 years.
I've been coming to this conference for 20 years. I came here first as a fellow in 2004. So I think it's just 20 years.
Just made it.
Yeah.
Well, why this conference?
I have always loved this conference. Like many years ago, it was still back in the Omni Shoreham hotel. All right, we're getting some nice hammering here.
Don't worry about it.
Ben gets rid of it.
They wait for us to begin recording, and then they start.
It's been quiet all morning.
That's good. Yeah, and it was it was just a wonderful experience because like back then Jerry Lucy was still sort of running the conference and kind of brought together the quality community, and then followed by Hot Topics, and you just got like this amazing introduction to not just everything that's going on in quality through Vermont Oxford, but then you also were able to really like listen to the latest randomized trials, which for us as improvers kind of is really what we rely on, what we want to know, so we can actually change care and like know what to implement, right? And so Hot Topics over the years has continued to just be this place where you get this like mix of both. There's a quality day on the first day. Munish Gupta's and Stephen Perlman are leading that and have been doing a great job doing that. And then like through Hot Topics, you continue to get just amazing speakers, randomized trials, and like even when I go to PAS, it's like the randomized trial session. It's like what everybody kind of migrates to. And so the other thing is really, it's just like you get so many international perspectives here, and that's I think for somebody who just practices in the US and has for 25 years, but kind of grew up as an infant and slightly larger infant to like 25 years of age, and having done internships in Germany, like it's kind of nice to see all the other things that are happening around the world and the practices that people have there, and the variation and innovation that comes out of that.
We've had people from Sweden, from Indonesia on the show this past 2 days. And it's always interesting because everybody deals with a different set of limitations. We all deal with limitations in the US, in England, in Canada. It doesn't matter. There's always a set of limitations.
Exactly.
And it's always interesting to hear what are the limitations people are dealing with and how are they solving.
And how are they managing?
So when we were talking to Rena about this, like they're transporting babies on boats and how they like this is insane. So I think this is absolutely interesting. You moderated a session on the first day of the conference called Lung Volumes and Setting PEEP Levels. We talked a lot about that on the podcast. We were discussing this with Risha Bhatia, with Amit Mukherjee. But it seems like this is really a topic of discussion. And we were reminiscing that this is always the question the fellows or the residents and interns ask you first, like, how high can I go on the PEEP? And it's funny that this seems like something
and
we
it
should
looks like we don't know the answer.
But can you tell us?
We're getting there.
But can you tell us a little bit some of the takeaways that you're taking back to Stanford from the conference, maybe specifically on that, or maybe on another
session.
One?
Yeah. I mean, I think that session was really like outstanding. It started with like Angela Cripps from Cologne. She was presenting their algorithm on how they take care of the 22, 23 weekers with like 75, 77% survival, and many of those infants off the ventilator, like a very low BPD rate.
Yeah.
and it was single-digit BPD rate, if I recall. And so, I mean, that's just incredible. And they're using a different kind of device, the Benavista valve. So it's like mostly flow driven. So, you can't directly translate it to a pressure in the delivery room, but they were giving out up to flow rates like in the mid 20s, early on. And, I think everybody in the US would sort of like freak out.
Aghast.
But she's got really she does have some pneumothoraces. She does have some spontaneous intestinal perforation. I think this is maybe something that we don't pay enough attention to. These babies usually have still a mucus plug, and we're pumping a lot of air into them, whether that's with a lot of flow or we're still providing 10 liters of flow or something like that in most of our devices. So maybe we need to actually think about whether what we do to kind of evacuate the bowel a little bit as we're pumping so much air into it when we're doing non-invasive ventilation. So that was, I thought it was really interesting. They're obviously, there's a lot of practices they do around these babies. So they try to kind of inflate them relatively fast, keep the fluids out of the lungs, and then kind of like over the first maybe 72 hours or so, they back off. And kind of maintain these infants. Now, many of them get intubated eventually, but at least for 5, 6, 7 days they haven't been intubated, or many of them. So it's very interesting practice. We'll see whether these things will make it here. Then I think we had the electrical impedance tomography.
Yeah. That was Ines
Freris from Kiel. And she has done like decades of work on this, and this was not something that was known to me. This kind of technology, and it's really it's gotten to the point where different companies have provided solutions that are actually relatively non-invasive and allow you to kind of monitor the lung in real time, which is...
This is something that we wanted to bring up on the podcast next year, because it is very interesting how, like you're saying, it's very non-invasive. It's basically like a little strap that you can put around the baby's chest, and you can get very interesting data from the lung themselves, and maybe titrate your interventions based on that data. So
that's right.
We're gonna try to give people more information about that, because it is definitely something that is rolling out in many units around the world.
Yeah, and it's happening like more so in the adult world, but there's many potential applications during surgery, or in the delivery room, or maybe even long-term ventilation, just to, you always wonder, like, oh, these babies, we're turning them around, are they getting atelectasis or those kind of things? And, you could actually see it like in real time.
Cool.
That'd be nice. Maybe also save a lot of x-rays, and, could have secondary benefits. And then we were kind of had some more,
and then
speakers from Risha.
They came on the show and shared with us.
Oh, they did. Okay, great. So I won't rehash it. But in general, for us Americans, right, like relatively high PEEP rates, right?
What do you think about this? What do you think about the fact that it seems that in neonatology right now, we're really looking at these interventions in the form of a holistic approach to our patients, whether it is in the US, I think Iowa is a great example. They have a very interesting approach involving hemodynamics assessment and other tools. But this idea of, like, instead of just looking at intervention, we can look at like the Cologne vision for prematurity, or the Iowa vision for, or the Japanese.
It's really a bundle, right?
But it's like a mega bundle, right? It's a philosophy of saying, well, we're gonna try to mitigate these outcomes. We're gonna try to accept maybe some complications, because we're very good at managing these minor things. I think that's an interesting shift that our field is taking, where it's like a certain way of doing things instead of individual interventions.
Yeah, it's really interesting. Quality improvement has sort of done this for a long time, right? There is always a little bit of dissatisfaction in that approach, and that you don't really know ultimately what works,
which ones,
right?
what is the key driver?
And exactly, and then there's many different approaches around the world to taking care of these 22, 23 weekers, and several of them apparently have much better outcomes than many of us, and so So like, okay, is it the Cologne approach? Is it the Iowa approach? The Japanese?
Yeah, and
like,
none of them
and
are
so,
the same
and they're
to
not
one
the same.
another, right?
Exactly, they vary widely, right? And so they can't all be correct. And so like ultimately, we have to. And then they also have different populations.
Sure.
Different
That's
populations, but
important too.
I think to me, what's interesting to me is that we were speaking about this at Delphi the first year with Fumihiko Namba from Japan, where you look at the individual interventions he presented to us about how they manage extreme preterm babies in Japan. And you can go one by one and say, well, the evidence is kind of not so great for this particular intervention. But when you take it as an aggregate, their outcomes speak for themselves. And so you're like, okay, so maybe we shouldn't look at each intervention individually and look at it on the aggregate. But what's interesting to me is that it forces you not to say, okay, we're going to be Japan now. We practice in South Florida. We're not Japan. But the idea is saying maybe it forces us to take inventory of our own local areas, our resources, our patients, our social determinants of health, and then decide what are the things we can address very well, some of the things that we can't address so well, and then try to build your own sort of bundle that makes sense for your patients. I don't know if you guys have any thoughts on that.
I think what I'm sometimes impressed with is that when I kind of go around the world, many of the places have the ability to have the physicians at the bedside for a much more period of time, and they're not sort of stuck in their cubicles for 6 hours a day,
right? If you're there with your patient,
and then you can kind of see what's happening. And I think, and maybe to some degree, there's also, there's a lot of innovation happening in the U.S., but there's maybe sort of the ability to try things a bit more than
outside the U.S.
Outside the
Yeah,
U.S.
for sure.
And so it tends to be maybe just a bit more innovative.
And who can be at the bedside is always interesting. We were talking with a physician from Sweden.
Yeah.
Well, parents have much more ability to be at the bedside than in the U.S., for example, where parental leave is more difficult. All these things you cannot equate everything together because these parameters do make a big difference.
Yeah, there are sort of things like, not all the things are great kind of for, sometimes it's like lack of resources that kind of brings innovation. So, when I was an intern back in Germany, I had to put together the respirators right before use, and so there was no respiratory therapist. It just didn't exist, and so we were a respiratory therapist and physicians at the same time. We had to understand what all the knobs mean and do, and then how to service the machine.
But it makes you really good at managing.
It makes you good at doing some of these things, right? And so it's a kind of an interesting philosophical thing about subspecialization and versus being more of a generalist, exactly, right? And there's things that you learn maybe through subspecialization that are superior to a generalist, but the generalist maybe also has certain advantages that the subspecialist doesn't see.
I will recommend the book Range by David Epstein that basically addresses that exact point of saying, are you better off just touching on a lot of different things and you'll end up being better at it versus just drilling down on one thing? The book opens up with the comparison between Roger Federer and Tiger Woods, and it's a very interesting book. It's a very interesting book. If you have, if you are,
that's quite a show. That's kind of the throwdown.
Yeah, for sure.
When we have you, I always had to ask, get the most out of you that we can. You are an expert in QI. You're an expert in healthcare disparities and healthcare policy. So, what role does QI have in mitigating healthcare disparities? And, what responsibility do we have as researchers, as clinicians, as people doing QI to really be attentive to those, the healthcare equity?
Yeah, wow, that's a 180-degree turn, and I appreciate it. A great question. Look, I think, to me, in many ways, I think quality improvement is equity work. This may sound a little controversial for some, because I know there's a lot of feelings that actually quality improvement may widen disparities. I actually think in practice that happens quite infrequently. And I'll tell you why. I think when you compare different populations with one another, and one is more disadvantaged than another, then I think what tends to happen is that there's sort of a performance curve that is steep and then flattens, and if you're performing already kind of like on the flatter part of the curve, not performing is maybe the wrong way, but that's also how we measure it, right? So when you're already on the flat part of the curve, improving gets harder and harder,
Mm-hmm.
right? And if you're further on the steep part, you benefit more from any improvements.
Understand.
And so I think that that quality improvement mostly will actually help the populations on the steeper part of the curve. And I think we've seen that in quality improvement really over the past 20 years when we've looked in many areas and where we've seen sort of general improvement, we tend to have seen a narrowing of disparities over time. And that's been really even without trying to specifically, address equity.
Mm-hmm.
And so I think the field has actually made progress. Now, the work is certainly not done. There's still a lot. We're working right now on focusing on safety net hospitals. And I think that's a really important area that hasn't been addressed enough. There's a lot of hospitals that have like low resources and that take care of populations with really high social risk. And so I think that needs to be an area trying to help those hospitals provide better care. And there's actually some when we started that work, we thought, oh my God, probably these hospitals will sort of all be on the bottom of the sort of California curve of hospitals because of the resources they have and the patients they take care of. But it actually turns out there are some really high performers amongst them in California. So it's not exactly destiny, So we're trying to figure out what is it in these positive deviants. What makes them special? We would expect them to do much worse, but they're actually doing great. And so what is it that they can do? And so we're trying to figure that out and then trying to help all the others and kind of lift them up and thereby kind of help all these populations that they care for. So, there's also a lot of things, of course, that we can still focus on, specifically equity focused in our work, and language is always one that comes up. And so, there's a lot of activity, and people are trying to sort of do the right thing and make changes locally. And I think that's very important as well. But I do like the quality improvement framework because ultimately I think you need to go beyond sort of education to actually change things. Education is kind of the first step, but it doesn't tend to just change things. So you need to link it to specific practices. And if you do that, you oftentimes reduce the disparity. If you standardize certain things, you reduce the disparity. And so it's almost like, well, it's good to educate. It's like actually change the process in a way that every population gets what they need. And then you need to take it out of the providers. You don't want to rely on the provider if the provider has biases or not. Like we can't rely on a system like that. Just build the system in a way that it just serves the population in the way that they need, sort of on an individualized basis. And I think that will help reduce disparities the most.
That's very interesting. Jochen, thank you so much for dropping by the booth, and congratulations on this.
You're welcome.
We'll see you next year at Hot Topics.
Good to see you guys. Big fan of the show. So whenever I bike or swim, I'm with you. You're with me.
We appreciate that. At least it makes us exercise as well by proxy.
Yes, absolutely.
Does it work that way? I don't think it works that way.
It totally does.
Bye.
All right. Take care.